And now we're going to introduce, all the way from Johns Hopkins in Maryland, Dr. Marcia Canto.
Good morning, everyone. I'm so pleased to be here. And Aggie, thank you so much for having me. I'm really excited to talk about the progress we've made on the second approach to fighting pancreatic cancer, which is to screen and survey to try to diagnose earlier disease that is curable. So I'm a gastroenterologist, and I want to talk about these issues today, the rationale behind screening and surveillance, particularly focusing on high-risk individuals, which currently is defined as patients with a genetic risk, but that definition is evolving. I'd like to summarize the research over the last 25 plus years and the progress we've made, including the diagnostic yield and the outcomes of screening. And I want to actually give you some hope in terms of the promising new strategies that we've been talking about, such as liquid biopsy. So why do we do screening for pancreatic cancer? You've heard the introduction. It's lethal. Everyone dies. But for me, it began in 1998. I'm a gastroenterologist. I do therapeutic endoscopy. And I met on the left with a family of a patient who came with obstructive jaundice. She had advanced cancer. And I went out to the family and I started telling them about what happened. And the two on each side of the patient on the left, the daughters, asked me, well, what about us? And I said, well, what about? And so I started taking a family history. And it turns out that there were 3 generations of pancreatic cancer in this family, of which there are 7 already affected. And they felt that they had something just looming above their head, that it was just at some point time for them to have pancreatic cancer, not knowing anything about it. And at the time, there was nothing really well known about screening. It hadn't existed. We didn't know much about mutations. We didn't know why some of these cancers run into families like this one. And interestingly, in this family, this patient here, who was the daughter I met with, was our first pancreatic cancer screen patient in our Hopkins program. And she had a stage 1 resectable pancreatic cancer. That was our very first patient. So you can imagine how excited I was at the promise of pancreatic cancer screening and surveillance. In 1996, this family was tested for BRCA mutations. They were negative. But eventually, with progress, we knew more about genetic susceptibilities to pancreatic cancer. And eventually, we found out that, in fact, this family had an ATM mutation, which is also associated with pancreatic cancer. So things do progress over time, and we learn more. And I want to tell you that at least the 2 siblings were prevented from having pancreatic cancer by being in our program. Now, why do we do pancreatic cancer screening? We actually can see some of these precursors. At the bottom is an endoscopic ultrasound picture of a pancreatic cancer, a ductal adenocarcinoma, which is what we know is at presentation. But on the 2 sides, we have mucinous neoplasms, which really are visible precursors. They're cysts that we can see on MRI or CT scan. But in the middle, But in the middle here, you can see that this is a pancreas in body tail area, where you can see these subtle changes, and you can see these tiny little cysts, which we now have learned are actually microscopic precursor lesions. They're called PANINs, or pancreatic ductal epithelial neoplasia. These are also microscopic precursors of pancreatic cancer that we now know the genetic composition of these tiny duct lesions actually mimic those of pancreatic cancer. So this is what happens with microscopic PANINs. They begin with normal ductal epithelium called PANIN 1A and B, and as they progress over time with these mutations that progress, you can see now they have this mucinous epithelium, sort of from cuboidal to columnar epithelium, almost like having an adenoma in the colon in your pancreatic ductal system. And as the accumulations progress, you can see that now we have certainly the well-known KRAS and CDKN2A mutations that we are now very early in the disease. But then in more advanced disease, P53 and SMA SMAD4 are actually the more advanced mutations that are hallmarks of high-grade ductal neoplasia and adenocarcinoma. There are also methylation changes that occur along the process, but it's these 4 major driver genes that drive from a normal duct to a cancer. And so we have this understanding now over the years from studying patients and their families. So what are the goals of screening? Well, we have risk stratification. We can't screen everybody in the population, but we now identify high-risk individuals with a genetic predisposition by taking a family history and testing them for gene mutations. The goal is to detect early curable ductal cancer, preferably the high-grade precursors like we would in a colon polypectomy, and prevent cancer from happening. That's a dream, isn't it, Aggie? And so I think with highly selective surgical interventions, we could even prevent pancreatic cancer from developing in high-risk individuals. Who is eligible for pancreatic cancer screening? That was a question this morning. Well, we've learned over the years, and based on epidemiologic data from risk associations, these are some of the eligible individuals who might be eligible for screening. There's a BRCA1 mutation carrier who has at least one first-degree relative and any two blood relatives beginning at age 50 to 55 years old. BRCA2 individuals, similarly, with a blood relative. PALB2, which is partner and localizes BRCA2 gene. They're also in the same family of gene functioning with at least one member. And the ATM mutation, as I mentioned, is also, again, similarly predisposing to breast, gastric, and other kinds of cancers, but also are linked to pancreatic cancer. There's the Lynch syndrome, which is a familial colon cancer syndrome, but also gives rise or is associated with pancreatic cancer. So these individuals can be started at age 50 to 55 years old, or 10 years younger than the youngest member of pancreatic cancer in the family. You also have the very rare genetic syndromes, which is FAM, familial atypical multiple mole melanoma syndrome, which is a big mouthful, but it's actually a mutation in the CDKN2A or P16 gene. Very, very rare, but very, very highly penetrated, dominant with pancreatic cancer. They do not need a relative affected, and we start earlier at age 40 because they get their pancreatic cancers earlier than others. Hereditary pancreatitis, again, another very clear-cut hereditary pancreatitis syndrome, lots of pancreatitis in the family, autosomal dominant mutations. Again, no affected relative required. Peutz-Jeghers syndrome is a mutation in the STK11 gene. They get all kinds of cancers, lung, breast, uterine, GI cancers, as well as pancreatic cancers. Again, these patients get even younger pancreatic cancer, so we must start earlier in their case. And then we have the bigger group of individuals where there's only familial inheritance, where you see their relatives affected, but no known mutation as of yet. And so we defined, at least currently, that there should be at least 2 affected members related by first degree in the family to be a familial pancreatic cancer family. And so, for example, you have to have a parent, a sibling, and a child, and the individual related to them who is not affected is eligible for pancreatic cancer screening. We do recommend really that there be consideration of full panel genetic testing to detect an inherited mutation, which one may not know about in the family, because that actually makes a big difference. I'll show you in a minute. So mutation carriers who have a family history have a greater risk of progression to pancreatic cancer than those without a mutation. So this is the study we published years ago where the overall risk was actually modest. It's about 5% over 10 years. But you can see here from the chart that the higher line is actually the progression rate of individuals to either high-grade dysplasia or cancer, invasive cancer, who have mutations, compared to the lower line here, where you can see the risk is 9 versus 15%. So it's actually almost double the risk for someone without a known mutation. So it's really important to really emphasize genetic mutation testing. The progression of these individuals can occur over many years. It's lifetime, right? You don't change your genes. And this is how we plotted over 300 patients that we followed over the 20-plus years we've been doing screening, where you can see that there is a steady progression as patients get older, that you can actually have individuals start at age 50 or 55, and they may be in the program getting screened for years before they develop anything. Hopefully not. But the hope is that we will track them and we'll find these precursors or cancers before they become lethal. The average time in our program from baseline to progression to cancer or high-grade dysplasia was about 5 years. Some people had 10 years. And so some patients, again, may need many years of surveillance. And this poses to us a very challenging practical dilemma of how to do this, how to engage with patients, the economy of all this testing over many years. What tests should you do? And that, again, really is something that should be considered in any screening program. How should we screen or survey these individuals? Well, we begin with a baseline EUS and endoscopic ultrasound. I'll show you that in a minute. And an MRI, which you all know about, which actually eliminates the risk of radiation exposure over time. We also now are recommending a fasting blood glucose or hemoglobin A1C to screen for new onset diabetes. And on follow-up, again, we do alternating imaging tests, typically annually, unless there's a mutation in the family or individual, in which we may do even closer surveillance, or if there's a lesion that we're following very closely. Again, we do annual glucose checks. We also do serum CA19-9, which I'll talk about in a minute, which again is troublesome as a tumor marker, but again, if it's really high, then would raise really great concern, particularly if there is a lesion that we see on imaging. So for those of you who don't know what endoscopic ultrasound is, it's a gastroenterology GI endoscopy test where we have a patient under sedation. There's a scope which has fitted an ultrasound transducer at the tip, as well as a camera we can see inside. We pass it inside the stomach, as shown here, and we actually can see the pancreas completely from the upper GI tract. We see the head of the pancreas here, the body and tail from the stomach, and the pancreas is just underneath the stomach, and it became very convenient in the 1980s to develop a technology that brought us so much closer to the pancreas to allow us to see much better and to actually get biopsies if we need to without associated pain. So this is really the standard clinically for viewing the pancreas and obtaining samples from the pancreas. So what does early detection of pancreatic cancer mean in a person? These are true stories. Well, we had a general surgeon who had 5 affected relatives. He heard one of the conferences where John Cameron talked about our screening program, and he volunteered to be in our study in 2003. And so he was age 59, he had a normal pancreas, and he came every year. Every year he'd have his imaging studies. And then 6 years later, he develops tiny cysts, which are pretty innocuous, nothing that anyone would be concerned about. And then later on, 2 years later, we had more cysts develop. And we were, it's like, developing polyps, I guess, in the pancreatic duct, still not meeting criteria for resection of pancreatic cysts. And then finally, at year 10 of his surveillance, here is the smallest pancreatic cancer you will ever see. It was detected under surveillance. It's a 7-millimeter cancer proven by both biopsy and by surgical resection. He underwent a total pancreatectomy, and that was 8 years ago. What other precursors do we see? Well, when we did the original studies, 40 to maybe 45% of patients that we screen at baseline have one of these precursor cysts. So they're very, very common. Most are small. Average size is about 1/4 of an inch. And here's the comparison between EUS, CT, and MRI when we did all 3 tests in the same patient to compare them blindly. And you can see here that MRI is close to EUS in terms of detection of all the lesions we found and also detection of patients. So MRI and EUS did become the standard for screening program in terms of what we would use for surveillance. This is another example of how we, in a patient, can find these tiny cysts, such as this one. This is the tail of the pancreas, endoscopic ultrasound. We're in the stomach. And you can see here that there are multiple cysts. Here's the pancreatic duct. There's some changes of chronic pancreatitis. And this patient had concerning findings based on the number of cysts in her pancreas. She actually did have surgery. And here is the pathology of that. So interestingly, for the surgeons here in particular, this is a 4-millimeter IPMN based on histology. But here's another one that looked exactly the same on EUS, and it was a high-grade pan-in microscopic lesion. Each one of these can become pancreatic cancer at any time. So, and here's the microscopic view of what that means. This is the target for what we would like one day to basically prevent pancreatic cancer in patients who are high risk, not to wait for it to become an invasive ductal cancer. So we can see some of these we can't. Have we made progress, Aggie? I want to show you that we have. So here's our earlier paper which showed the shift in the stage of ductal adenocarcinomas detected in our screening program. On the yellow bars or orange bars, you can see 72% of our Hopkins detected pancreatic cancers were resectable. These are mostly, I think, all asymptomatic based on the screening program, as compared to the SEER, the standard US stage of resectability was only 28%. And again, this is what we know about, that most patients with symptomatic pancreatic cancers are unresectable. The minority of them are actually not resectable at presentation. These are mostly patients who actually fell out of the program, didn't come back, or felt that they really were tired of it. So again, this is a message that we want to understand. Now, what is the stage shift about? Well, you can see here that we now are finding stage zeros. What are stage zeros? These are the high-grade dysplasia lesions, high-grade IPMNs, high-grade PANNs that we are actually, fortunately, able to find. The local stage about the same. But here's the shift here. You have more regional stage 1, 2s that are actually also still treatable in current times. with much, much lower proportion of metastatic disease in screening. So this is the stage shift that we wanted to have, and this is still going to improve over time. So what does it lead to? Screening and highly selective surgical treatment does improve survival. This is the curve that you want to see, Aggie. Here is all the patients who had precursor, high-grade, non-invasive lesions were all alive at the time of the analysis. Nobody had died. And these are the patients with cancer who had been screened and detected during their surveillance program. Look at their survival curves compared to the symptomatic patients. 3-year survival rates were phenomenal, 85% at 3 years. You will not see this in any clinical trial, compared to 25% in those, again, who were diagnosed outside or with advanced disease. And here again is the 5-year overall survival. And I'm proud to say it's still 60% substantially alive at 5 years, compared to what we know, 20% are alive at 5 years. So this is curative. This is a curative approach that we're talking about here. So in the systematic review, this is one publication of 16 studies talking about pancreatic cancer screening, high curative resection rates, longer average survival time, more stage 1 PDACs found in high-risk individuals undergoing regular surveillance. And you can see here that most of these were diagnosed by endoscopic ultrasound. Some of these are too small to be seen by standard imaging, including pancreatic protocol CTs and MRI. So we must incorporate EUS as part of the algorithm. And most importantly, how are we impacting our families? How are we impacting the patients? These are true stories I want to share with you. So this is the gentleman I showed you with the small pancreatic cancer, the surgeon. He's retired, of course, and this is a true email that he sent me. Hi, folks. 6 years ago, this time I was in the operating room at Johns Hopkins. Quite the day. I have done well since, surviving, more than surviving, thriving. We did a 6-day, 140-mile bicycle tour of Normandy and Brittany, France in September. Wonderful. Forever grateful. And so this is him with his grandson. This is a true story. Another true story. This is a librarian from Missouri. She came to our CAPS program years ago. She had 3 affected relatives. And we want to show you here that screening does detect precursor cysts, IPMNs, as well as pannins. And this individual had a small, innocuous IPMN in the head of the pancreas and also multiple smaller cysts in the rest of her pancreas. And at one time, she actually had a progressive disease in terms of having more cysts develop. And she had a distal pancreatectomy, which actually showed low-grade IPMNs and some pannin 2s. But later on, 2 years later, and this is a time when we didn't know what kind of operation to do. Should we take out the pancreas on everybody? This was all unclear. 2 years later, she was ready. She wanted the rest of her pancreas out. And at that operation, she actually had multiple. She had 10 pannin 3s, which is the high-grade dysplasia duct lesions. We were just in time. She was probably going to get cancer in the next few years, and she was very prepared for insulin, diabetes control, and she's really been a marvel. So this is just several years ago, 9 years after her surgery. She tells me, I feel great. Never realized how depressed I was until after my operation. I am so relieved, she said. I want to write a book to help other patients go through this. Our research, pancreatic cancer surveillance, I haven't published this yet, but we have shown that it does, in fact, improve worry and quality of life with high satisfaction in our surveillance program. One more story. The story of a branch duct IPMN, a benign cyst lesion to cancer in 8 years. This is a success story of surveillance. So this is a 61-year-old woman with 2 first-degree relatives, a sister who was age 22 when she had her cancer, no known mutation in the family. She came into our program and she had multiple cysts with moderate chronic pancreatitis. She kept coming. 2016, she developed this very concerning mildly dilated duct in the head. No cancer was seen then, no mass, nothing to operate on. But 1 year later, she has this now I guess it's not going to play. She has this cyst associated with a solid component, and this is her cancer. She had a resection and a Whipple operation, which was uncomplicated. And now we are proud to say that she, Sister 1, is alive, well, with no evidence of cancer 4 years later. And her other sister, who was detected in our other sister screening program in Boston, who had a Whipple too, is alive 8 years later. So we call them the Whipple sisters. So a very, very fantastic story of survival and success in screening. So how can we improve early detection and prevention? We're obviously not perfect. We're far from perfect. And we're still learning how to do better. And so you've all heard about liquid biopsy, and there is the promise of blood-based biomarkers that were not around when we started this 2 decades ago. And so I'm pleased to just give you a short summary of what I know, what is out there in terms of at least the more developed blood-based markers. I'm sure there's a lot of research going on in different institutions, as was mentioned this morning, but these are some of the markers that already have made a few steps forward, and now you want to know about these. So there are several biomarker approaches for blood-based testing and screening. There's the proteins or the antigens. There's circulating tumor cells or CTCs. There's exosomes or the vesicles released from cells, which were what was talked about this morning. There's circulating tumor DNA or ctDNA. And then there's cell-free DNA. This is DNA floating around in your blood without cells associated. The most challenging part is not only the technology of the science, how to actually find these components of cancers or cancer-related particles, but the minute amounts of circulating DNA or biomarkers in the blood, especially when you want to detect very early disease, it's almost impossible. It's like a dream, right? But I think we're getting close, and I want to show you how. So one available blood test is blood glucose. We've learned a lot about diabetes in recent years, and it's interesting that about half of patients with pancreatic cancer have diabetes. This is induced by the cancer. The mechanism is unclear. But when you remove a pancreatic ductal cancer in someone who had new onset diabetes, the diabetes gets better or goes away. It's not clear why that is. New onset diabetes or NOD, diabetes within 2 years of duration, is associated with pancreatic cancer risk. 1% of older patients with NOD develop pancreatic cancer, about 8-fold higher risk of developing cancer. So you may identify asymptomatic patients with NOD out there in the general population without any family history who may be at risk for developing pancreatic cancer. So in recent years, this has become a real target for screening and surveillance. It defines this group, particularly with the work of Suresh Chari and his group, of patients with NOD, even without a family history, who can again be filtered for screening or surveillance and developed an NPAC score, which incorporates the age of the patient, body weight, and blood glucose levels in order to risk stratify patients for further imaging and evaluation, such as imaging, MRI, or EUS. And again, this is a subject of great research at current times. There's 2 ongoing trials in clinicaltrials.gov that I found. They're actually following patients with NOD, over 10,000 patients over the next 5-10 years, which is going to be very interesting to see. And we'd like to see those results sometime. But again, in theory, at least based on our genetically predisposed individuals, the CAPS Consortium is recommending annual testing for blood glucose and hemoglobin A1C in patients to detect NOD in our patients, regardless of symptoms. There's another test that we know about, serum CA19-9, Carcino carbohydrate antigen CA19-9, may be familiar, is a glycoprotein related to the Lewis blood group antigens, and it's been around for many years as potentially related to pancreatic cancer and other cancers. It's certainly elevated not only in pancreatic cancer, but bile duct cancer and other cancers. But unfortunately, it has poor sensitivity. And the reason is, at least one of the reasons is that there may be a lack of the functional enzyme called FUT3, which is needed for CA19-9 formation, synthesis, and which is present in 5 to 10% of the population, right? So there also could be false positive CA19-9 being elevated when there's obstructive jaundice. So it's best not to use this as a diagnostic test for pancreatic cancer, but currently, at least clinically, it's used for prognosis, to assess response to treatment, and also to diagnose recurrences. So for example, if the CA19-9 is elevated before surgery, it goes down after surgery. If it starts creeping up again, you're really worried now about a recurrence that you may not be seeing, and then treatment sometimes is initiated for possible recurrences. And so again, has been the role, that's been the use of CA19-9 in our practice. Now, our Johns Hopkins group, in collaboration with my partner, Dr. Goggins, who runs the early detection biomarker lab at Hopkins, published this paper where we actually looked at the gene variants related to CA19-9 in patients with high risk and those without. And it turns out that there are 3 genetic subgroups based on SNPs that really affect the CA19 levels in your blood. So in fact, he's developed a nice way to actually individualize the CA19 levels based on your genotype. So it's almost like personalized medicine. What is normal for one person may not be normal for another person, et cetera. So in fact, this is a clinical test now available at Johns Hopkins. We're beginning to initiate a clinical trial, a study involving our high-risk individuals to see if, in fact, CA19-9 may be very helpful in screening and surveillance. So the adjusted cutoffs using these genotypes actually shows improved sensitivity and actually with stable specificity. So again, there's a promise of CA19-9, which is personalized for your genotype, may actually be helpful along with your other biomarkers. There are novel biomarker tests, and I'm going to just mention them just briefly just because of time, is that there's tests that are multi-cancer screening. They are blood tests that actually detect multiple cancers, not just pancreatic cancer. So I'm going to go through these very quickly. And there's one test that is pancreatic cancer specific, the IMRAY PanCAN-D by Immunovia. Again, I will discuss this. These tests have made it out of the academic basic science labs and into industry. And that's a big leap. It's very difficult to have an idea, transition it to an assay that eventually can get manufactured and licensed and basically done in CLIA labs for patients to get, for us to know the results and actually intervene and act upon these results. So there's actually a long pathway to that. Now, Blue Star Genomics has a test which basically is based on the changes in DNA methylation, which is a common pathway for cancer. It detects hydroxymethylcytosine signatures in cell-free. This is a cell-free DNA test in the blood. So the current target, and this is what they're studying, is the pancreatic cancer and new onset diabetes in patients who are greater than 50 years old. So on clinicaltrials.gov, you'll find that trial ongoing. It has decent sensitivity and very high specificity, which is what you want with a pancreatic, with a screening test. You don't want a lot of false positives in healthy individuals, but it's not yet FDA approved. It's a laboratory test that will imminently become available and eventually be FDA approved, hopefully with more data. The estimated cost is around $1,000, so ain't cheap. It's not like a CBC. The other test is the Galleri by Grail. It's also a targeted methylation assay analysis of cell-free DNA, same principle. In this one first study that they have now, I believe, published of more than 6,000 individuals greater than 50 years old, you can see it detected a lot of kinds of cancers: breast, colon, rectum, liver, pancreas. All of these were detected. In these 6,000 individuals, only 29 cancers. These are patients with just a blood test detecting cancers. It's remarkable, obviously. 0.4% prevalence of cancer, possibility value of 45%. And interestingly, 40% of these cancers were stage 1 to 2. So not all are metastatic, which is really very encouraging. And so again, not FDA approved. The test currently costs $949. This is from the company. CancerSeq. CancerSeq was developed at Johns Hopkins and first reported in 2016 by my colleagues, Dr. Lennon, Bert Vogelstein, and their fantastic DNA lab. It can detect cancers from 10 organs, including 7, which have no recommended screening tests. So pancreas, ovary, liver, stomach, esophagus. We do screening for colorectum, breast, and lung, but all the other ones, all of these together, account for 60% of the cancer deaths in the United States. So hopefully with this successful multi-cancer test, you can actually make an impact on overall cancer death. The DETECT clinical trial was finished and published. 10,000 women, mostly were, and these are the 26 cancers that were not routinely screened for, meaning they discounted the colorectum and the breast and other cancers that normally you'd screen with other tests, and these are the ones that only would have been found with this cancer. None were pancreatic so far, and certainly there's still DETECT 1, 2, 3. There's still ongoing trials, still evaluating CancerSeq, and we're very, very encouraged. We're very optimistic about what CancerSeq may do. It was licensed. It was licensed by Exact Sciences. You know, the Cologuard. They make Cologuard, and so we're hopeful that with that platform and with that support, it will go forward as a clinical test. So this is the original publication in 2016, where Dr. Lennon reported, and her group reported that in 1,000 patients, you can see here the arrow is pancreatic cancer, 99.5% specificity, and very decent sensitivity, 25% stage 1. Most were actually stage 2 and stage 3, which currently are pretty treatable in the oncology world. So pretty encouraging for the first time analysis of what this can do. The next test is IMRAY PanCAN-D. It's a pancreatic cancer-specific multiplex antibody-based test. So basically 8 protein biomarkers plus CA19-9. Okay, so importantly to note that they also incorporate biomarkers plus CA19-9. Basically, it's immunohistochemistry, machine-based learning, artificial intelligence. They actually are able to, with these different proteins shown here, be able to predict your risk in terms of low, medium, high, and you can therefore potentially undergo further evaluation. So this is the first study. This is published by our colleagues, Dr. Brand et al., published in, I think, this year, where you can see that, again, this is from bank blood samples. This is not in people being recruited prospectively, 10,000 people. This is sort of a case control. But again, the fair number of pancreatic cancers, some healthy controls. Sensitivity really high, very encouraging for stage 1 and 2 disease, high for all stages, which is probably one of the highest reported. But the caveat is that this is very, very enriched, if you call, with pancreatic cancers already there. So there's some bias from that, and I want to point that out to you, that these really have to be validated in prospective trials. So again, not FDA approved. It's an LDT test available in 45 states, costs $945. About the $1,000 mark seems to be what the competition is running for these blood-based tests currently, right? So finally, liquid biopsy test, what are the pros and cons? Certainly very attractive, non-invasive, testing between annual imaging, which we already have been doing in our program for high-risk individuals. Obviously, potentially life-saving if you find a cancer that's resectable, treatable, and asymptomatic. There might be reduced healthcare costs due to early detection of cancer. We don't know that yet. That's pretty far down the line. But there are cons. There are a lot of them. They're not readily available. They're lacking clinical validation, the bias, again, from enriching the populations in case control studies. They're still very expensive. And at this cost level, not feasible. Not feasible for general population screening, I must say. Not only once, but with further, you don't just screen once in your lifetime. You have to do blood tests repeatedly, right? So again, this has to be all worked out, and hopefully the technology will get better, cheaper, for us to be incorporating them in our practices. False positives. So the specificity is what drives the false positives, and hopefully it has to be at the 99% or higher range, so not a lot of people who don't have cancer, who don't have symptoms, who have a positive test, won't be harmed. And that's really what the FDA is all about in terms of raising the bar. So finally, I want to end. I think my time is up. Screening and surveillance of high-risk individuals. I think I've shown you over 25 years of working on this is beneficial. It leads to a stage shift, leads to improved survival, and we can find cancers that are potentially curable. We are excited about liquid biopsy tests that have come to the front. These were not around in the 5-10 years that I've been working on this, Bill and Aggie. And so it's really exciting to have this as part of the platform for approaching early detection. We need more data, obviously. I do believe, though, that in this next decade or so, that precision personalized medicine approach, together with artificial intelligence, machine learning-based algorithms to incorporate all this information on family history, genetic data, environment, smoking, et cetera, diabetes, imaging, and biomarkers, is really the future for the next 2 decades. So please stay tuned. Thank you very much. I forgot to give credit to my team. This is my CAPS team. It takes a village. These are the surgeons, gastroenterologists, pathologists, radiologists that started the CAPS program. It was 25 plus years of our Hopkins pancreas screening program. It's become a global community. We have an international CAPS consortium involving 4 or 5 continents and 30 plus countries all over the world. So there is a family, Aggie, of screening and early detection programs that has grown over the last many years. And so I want to just end with screening does give hope. So please stay on and stay tuned for all our progress in this field. Thank you very much again.
Thank you. Dr. Canto, that was phenomenal. So good. I've been asked that if you do have a question, you do need to come stand up at the mic so that it can be recorded. So if you have a question, don't be shy, come on up, and I think we're ready with the question on the other side.
So for some of us who have been having surveillance for a decade and a half, is Johns Hopkins doing any kind of work on long-term effects of contrast from MRI, MRCP?
Yeah, excellent question on MRI. So it is actually one of the concerns people have. We frequently bring this up in different conferences and also with our radiology experts. What has been reported is the gadolinium with some collection of something in the brain, which they don't know has any clinical significance. And it doesn't appear to really accumulate to the point where we would be concerned about repeated gadolinium. There are newer agents that are being given, and as far as I can tell, all our expert radiologists are really not concerned to the point of the evidence available that would raise the bar for us to eliminate gadolinium. Gadolinium is necessary because it actually allows us to see cancers. Cancers are vascular. and you need contrast in order to see vascularity. So you can have a non-contrast MRI. It'll only show you cystic lesions like ducts and cysts, but it will not be able to show cancers.
But is this data from long-term? I'm talking about people, some of us are doing this for 10, 20 years.
We have no information. We are not we're not doing brain MRIs to see if there's collections in the brain. And certainly we haven't had any real reports of any concern.
I have a question. I'm a pancreatic cancer survivor, 8.5 years. I had a Whipple in 2013. I also had genetic testing, and I do carry the ATM gene. I have a daughter that tested positive as well with the ATM gene. She is 33 years of age. I guess she just turned 34. And the ATM, showed up as breast cancer as well, and she ended up recently having to have a mastectomy a couple months ago. So I'm curious on, how often or at what age should she actually start testing for pancreatic cancer gene? They haven't done any testing in thus so far for that. Only the breast cancer has been discovered for her. So what age should she be tested?
Yeah, no, so thank you. I'm sorry, how old were you when you got your cancer?
I was 58.
58, okay, thank you. So it's either 10 years younger than the youngest cancer in the family, so be 48. Or 50 or 55 years, whatever is earlier. So age 48 would be a good time for her to start. And the reason is it's thought that pancreatic cancer, and even if it's genetic, doesn't really, unless there's a young onset pancreatic cancer in the family, doesn't really start in susceptible individuals at an earlier age. Routinely, the average or median age for pancreatic cancer development, even in families, is 65. Most patients are older, except if there's a young onset pancreatic cancer in the family.
We've got a few here.
Thank you, Dr. Canto, for your talk. My question is for people that go through a liquid biopsy, what would be the recommended frequency to repeat that to take advantage of newly discovered gene mutations?
So these are somatic gene mutations, you mean, or
So,
a mutation?
for instance, like the BRCA gene. So I was originally screened in 2013. I repeated the test about 4 years later, which came out with CO50, which hasn't been elucidated as to its pathogenicity. But just wondering, over time, as more genes are discovered, what should be the frequency to repeat the test?
So the question about liquid biopsy frequency or screening frequency, surveillance frequency, liquid biopsy test?
Yes.
Okay, we don't know. I think it's the studies I showed you were mostly in the first validation phase, case control. They have bank blood from years of collecting these in people without cancer, and there are people with cancer that are known, and there are people who are normal and healthy, and that's what we have today. There really isn't any long-term study of any of the liquid biopsy assays that have yet been completed. So, and whether or not, we're proposing that at least it be done once or twice a year, so one during the imaging in high-risk individuals, and between imaging tests in order to potentially detect any interval cancers that may be developing between imaging tests. So it's all currently hypothetical.
Thank you.
We have a question from Zoom. How do these blood-based assays complement the data found in the EUS MRI surveillance study to determine when a patient transitions from precursor to pancreatic cancer? And a follow-up, is there any data looking at the correlation of KRAS mutations in the circulating DNA of the new onset diabetes patients that might or may not have pancreatic cancer?
So I'll answer the second question first. I think we just don't have the data. These tests are just beginning to be studied. And they certainly have been combined with new onset, so basically the new onset diabetes trial is ongoing. They're using that one assay, that company, but not any of the other multi-cancer ones. And in terms of where these fit in, again, it's all proposed that we obviously try to get repeated testing to detect very, very early changes in the blood. There is, again, this is so early that they're still developing in conjunction with the FDA what the proper protocol would be, what proper target it is. So, for example, Cancer-Seek, the next validation study is already planned and hopefully imminent to start, but we just don't know yet. But I think there's just such an excitement that it'll help.
Hi. I'm a stage 1 pancreatic cancer, distal pancreatectomy, splenectomy. Had surgery, had 8 rounds of Gemsar, going on close to 2 years, cancer-free. I have a series of little questions. For the one gentleman that had the very tiny cyst, why did he have a total pancreatectomy?
So yeah, thank you. That was the surgeon. He had a cancer, actually. It wasn't a cyst. It was a solid lesion.
I see.
And there it still is not a great agreement amongst oncologists, surgeons, and gastrologists about what the proper operation might be in someone who has a cancer and also has precursor lesions in the other parts of his pancreas. As you know, with cancer, they won't usually they try to spare as much pancreas as they can, and also considering the effects of total pancreatectomy, of course. And so at our place, when we began, our surgeons and we had decided that if someone has a cancer, sometimes we would talk first about a local or subtotal pancreatectomy, depending on where the lesion was. And that was because what drives the survival is the cancer. If there's a cancer recurrence, then why would you basically give someone the added problem of dealing with having no pancreas, right? So, but with this very, very early cancer, and with him having other small cystic lesions in the rest of his pancreas in the body and tail, these could potentially become pancreatic cancer, even if he's cured of the one that we found, right? And we all know that there's this, that I've shown you those microscopic precursors called pannins. We don't see all of them. And I think based on the decision-making process, that's what he and the surgeon decided on. It was the best thing that he did.
Okay. Another piece of that question, what's the recommended monitoring post-surgery, post-chemotherapy? What types of monitoring? I think you covered some of that, but what frequency?
Well, maybe the surgeons in the group have, or oncologists have their own protocols, but at our place, they always get a pancreatic protocol CT scan minimum annually. Sometimes they actually come much sooner than that for follow-up. They also, at our place, get an endoscopic ultrasound, and they would return to a surveillance program that they were having before the surgery. There's not yet any incorporated blood-based liquid biopsy markers. These are all part of protocols, but clinically, that's what we do.
How often would you do the EUS?
We would probably do it at 6 and 12 months in the first 3 years, sometimes just annually if there's really no disease and there are no other lesions in the pancreas.
And is there much reliability with the CA19-9?
Right, so, as I told you, if it's high, it's good to predict recurrences, right, if it's high and it goes down. And I showed you the work we're doing on the personalized levels of CA19-9. So we're hopeful that that's going to make it better in terms of the sensitivity as well and how it performs with, it's not as a standalone test that can be used clinically, but also with other markers the way those other blood-based markers have done.
Okay, excellent presentation.
Thank you very much.
Oh, no.
I just had one more question. I was curious on other family members in my immediate family that tested negative for the AT mutation, which I carry. How often should they be tested, or should they just think, oh, they're safe, and feel like that they didn't have the ATM? So, how often should they be tested?
So that's like the best question of all morning.
Yeah.
I say that because we didn't know much, again, 10, 15 years ago, and we had one of our metastatic pancreatic cancer patients that I showed you was exactly that family. So I think the aunt or the first-degree relative of the person who was in our CAP study tested positive for a BRCA gene, and the person in our study tested negative, like as you said. And so after the first screening baseline visit, he decided not to come back because he felt, I'm off the hook, I'm not at risk, I don't need to have surveillance. And 4 years later, he develops a pancreatic ductal cancer that's metastatic. When we tested him, he had an ATM mutation. And so it's interesting, some families may have 2 mutations running in the family. And remember, not all pancreatic cancer mutations are known. There's this big group of familial pancreatic cancer kindreds where there's not a known mutation, and we just don't know what it is. So if you're negative, that doesn't mean you're off the hook, is the message I'm giving.
Okay, thank you.
Okay, before we break, we're going to do one more question on each side.
Thank you. That was a great presentation, really informative, so thank you. I have lost 4 family members to pancreatic cancer, my mother, father, grandmother, and uncle. I was diagnosed early because of losing family members. We have 2 sons, 33 and 45. Their doctors are not interested in testing them for pancreatic cancer at all because they have no symptoms. I don't understand. What do we need? I was diagnosed at 45, and it was early only because, like I said, I'd lost family members and sort of requested it. But they don't seem to take it serious because there's no symptoms, and I had no symptoms either.
I think it's hard to know. I think the data on pancreatic cancer screening and surveillance are not yet fully out there that people know about it. But certainly the Hirschberg Foundation and PanCan, all the other groups that are trying to promote education and learning would really, I think I would just advocate for, if he wants to reach out to me or anybody in our group or anyone in any of the centers in the CAPS consortium, we're certainly happy to share data. Some people are data driven. They'd like to know, well, what's the evidence, what's for. And so we're happy to share all of that. 20 years ago, there was no data, but now we have abundant data that really supports screening and surveillance.
Okay, thank you.
Okay, last question.
Thank you. Hello, I just have one, I hopefully is a simple question, is what is better, which is the best screening that you can do? Like my doctor does every 3 months to 6 months, has always been a PET scan. Is an MRI any better than a CT scan or PET scan?
Right, so that's an excellent question too. I think PET scans have a threshold of detection of cancer, and again, if there are any oncologists in the group, correct me, or radiologists, of about 1 cm in size. So they can't really potentially detect really, really tiny. This is for cancer recurrences. So the goal of PET is to detect a cancer, and particularly in your case, a recurrence. The goal of the other imaging tests, which is MRI and EUS, are to detect new lesions, new disease that may be in the pancreas you have left, right? So it's like having several colon polyps, one colon cancer on one side, and you can develop another colon cancer on the other side that's left behind. So it's like mammogram. You need to mammogram both breasts, like even if you have surgery on one. So it's a field effect you have to deal with, not only residual disease or recurrences, but also the potential for more disease, more cancers developing in the precursors.
Okay, so am I clear on that? I'm sorry. So then a PET scan would be appropriate
So
if that's all I'm being offered?
Well, it would potentially miss precursor high-grade lesions, and it may miss very, very small lesions that are below the threshold for detection by PET.
Okay. So then an MRI is better?
So I think you probably should consult your gastroenterologist. I don't interfere with people's practices, but at our place, you probably would have an EUS and MRI at some intervals.
Okay. All right. Thank you very much.
Dr. Canto,
Thank you very much.
This has been a 24-hour trip for you from Boston. From
Baltimore.
Boston. Thank you so much. And it's been the most promising presentation I've heard in many years.
Thank you so much, everybody.